Hello, everyone. Namaste, namaskar. This is Dr. Prabhat Adhikari. I'm infectious diseases and critical care specialist, and today I'm going to talk about COVID-19, which is also known as SARS-CoV2, the virus that's been pandemic around the world. So, in this video, we'll talk about a lot of things, including virology, pathogenesis, clinical features, treatment and prevention, and a few other things we need to know. So, let's start the video. So first, let's talk about the virology or the virus itself. So COVID-19 virus belongs to the coronavirus family. The way the corona comes from crown, actually, if you look at the virus itself in the electron microscopy, you can see the spike proteins, they look like crown. So that's why the virus is named as crown or coronavirus. And one of the new viruses from the family is called COVID-19 or SARS-CoV2. If you look at the virus itself, then the virus has an outer layer of bilipid envelope that has lipids here, and there are a few other proteins embedded in the lipid layer. They are called S proteins, and there are some HE protein. And these proteins are important because they help the virus to bind to a cell, and also they have different other functions. And also from immunological point of view, if you want to make a vaccine or if you want your antibodies to act on it or your immune cells to act on the virus, then they need to identify these proteins. And within this lipid bilayer, you have this genetic material. So viruses, they either carry a RNA or they carry a DNA. So this virus is a RNA virus, and this RNA virus is one of the largest non-RNA viral genome. And I'll explain you later what's the implication of this virus being the largest genome in the next slide. So let's talk about how the virus replicates in a cell. So every time a virus tries to go into a cell, it always needs some receptor protein. So if there is no receptor, then the virus is not going to infect the cell. So anytime a virus is going inside a cell, always remember that there should be a receptor protein. Besides that, sometimes they also have fusion protein. Okay, so it goes inside the cell through binding through a receptor protein. So this is a hypothetical virus. In COVID-19, the receptor is S receptor, ACE2 receptor, and there are sometimes fusion protein involved in that. So it binds to the S receptor, the virus goes in, and it uncoats or it takes out its genomic RNA. So this is a positive sense RNA virus. So from the RNA, the RNA-dependent RNA polymerase enzyme makes it into more RNAs, negative sense RNA, and that converts to positive sense RNA, and then they form protein, and all this protein with the RNA, they go into Golgi apparatus, they pack together in fascicles, and they bud out. So it's very important to know this cycle, because when you target a medication, then you can plan on different sites of the replication cycle. So for example, if you can devise a monoclonal antibody that can bind on the protein of the virus, then it might prevent the virus from binding to the receptor. Or if you can bind a form of monoclonal antibody that can bind on the receptor, then that will prevent the virus from going in. And there is a new drug that works on the fusion protein, that's called antifusion drug. So if you can make that drug, then that will prevent the virus from fusing into the cell. So we use this kind of medications in HIV. You might have heard of fusion, or antifusion medication. So you can also try this medication, and some of these medications are on the trial. So, and there's something called giving antiserum. So if you give antiserum or vaccine, then that's going to bind to the virus and prevent it from going to the cell. So if you compare about the immunoglobulins, IgA is more active than IgG, or it's more effective in controlling this virus. The reason being, IgA is secreted out in the mucosa, and this virus gets inside through the mucosa. So if you can devise a vaccine that's predominantly IgA secretory, or that predominantly makes IgA, then you'll have better chance on preventing this virus from getting into your system. So let's go over again. So you can design a vaccine, you can design antiserum, you can form anti fusion protein medication, you can form monoclonal antibody or any medication that blocks this receptor, or you can also devise RNA polymerase inhibitor, and that medication is called remdesivir. Or you can also use protease inhibitors like we do in HIV, so they work here. And also you can hydroxychloroquine works here by changing the pH of the vesicle, so that the protease enzyme, they cannot break down the proteins and the virus cannot get packed, so there are a lot of different ways you can target medication to act on this virus. So now let's talk about the genetic structure of the virus itself. So if you look at the virus, then we are comparing different kinds of virus family with the coronavirus. So if you look at different viruses, then if you look at this picture, then coronavirus, they are pretty much similar to other viruses, and alpha and beta coronavirus, they are pretty much similar. So in any viral genome, example like the SARS-CoV genome, there's ORF1, ORF1b, and then they have this accessory structural proteins or genes. So if you look at it closely, then if you look at the COVID-19 genetic sequence, then if you look at the different viruses, so let's compare about different coronaviruses that became pandemic or epidemic. So in 2008, 2009, we had SARS coronavirus. In 2013-14, we had MERS coronavirus that came from Saudi Arabia. And now we have COVID-19, which came from China. So COVID, if you look at the structure of the COVID-19 and compare with all these two different viruses, then it's pretty much similar to SARS coronavirus that came in 2008 and 9. So let's look at SARS coronavirus and SARS-CoV2, which is our new COVID-19 virus. So they are pretty much similar in their sequence. The only difference you can see is few points, like 8B in the 8B sequence pair, and then base pairing 10. So only 2 or 3 mutations or point mutations have made this virus a totally new virus. So what I'm trying to say is that if you already have a virus, and if there's even a single point mutation, then sometimes this virus can become deadly. So now in the next slide, I'm going to show you how a mutation in the DNA or RNA can make a virus hypervirulent or make a new virus. So if there's any point mutation in the RNA or DNA that carries on to the amino acid sequence, and that's how the protein structure might change, or the charge in the protein might change, or there could be some isoform change. So few small changes in the protein will make it a totally different protein. So for example, there was a mutation in the DNA of the virus, and the protein that came out of the DNA had some changes in the protein itself, maybe the charge or some changes. Now this virus was only limited to animal kingdom. It was not able to infect any human being, but because of this point mutation, there was some changes in the protein, and now the virus can bind to a human cell, and now it's being able to infect a human cell. And that's how even a point mutation can make a virus really dangerous and a new virus. So what might have happened to this coronavirus, or how did we get this virus? To understand this, we need to understand more from the MERS. So when the MERS epidemic happened from Saudi Arabia, they later on realized that they traced out the index patient, and then they found this patient actually got the virus from the camels. And they traced back, and they found the camels got the genes or the virus from bats. So what was going on is that the bats, they were acting as carriers. They had a lot of coronaviruses, and they feed on the nuts. And while feeding on the nuts, some of the mutated viruses, they came off of the bats, and as urine or feces or some other things, and they fell on in the water. The camel drank the water, and one of the mutated virus was able to infect the camel, and from camel it was even able to infect the human beings, and that's how it went out of the animal kingdom to human kingdom. And that's how the MERS happened in Saudi Arabia. And then there was one case that took the virus to South Korea, and there was another epidemic focus in South Korea, and that's how the MERS expanded all over the world. So in the same principle, SARS might have happened from animal kingdom, and then there was some point mutation. The virus could change its behavior or could change its receptor, and now it was able to infect a human being, and then it became human to human. So that's one of the hypotheses. Whereas some people believe that because the virus closely resembles the SARS virus, some people they believe that it's been genetically engineered and made as a new bioweapon and made as a new virus. So there's a lot of controversy going on. So we don't know what's the exact truth. What's the truth behind it. But the virus can mutate, and there's always natural selection and survival of the fittest, as per Darwin's theory. So now let's look at the phylogenetic arm of coronaviruses. So actually, the family of coronaviruses, they have a lot of viruses. They have 50 viruses, alpha, beta, delta, a lot of viruses. So out of that, only 5 to 6 viruses are found in the human kingdom or human beings. The rest of the viruses, they are found in animal kingdom, like cattle's, dogs, cats. But most of the viruses in the animal kingdom, they are harbored in bats. So bats are usually a rich source of viruses. They not only have different kind of coronaviruses, but they also carry rabies. They were also thought to be the source for Ebola. So some people think that bats, they harbor all the viruses, but they don't get infected or they don't get sick. They act as carriers. The reason being, the bats they have higher temperature, they fly out a lot, so maybe their immune system is very robust and the temperature is very hot. So that's why they are able to fend off the virus, but the virus do survive in their nose and their respiratory tract, and that's how they transmit the virus to other bats or other people or other animals. So what might have happened to this coronavirus? So the current hypothesis is that the virus actually came from bats to snake or this animal. I don't know the name of this animal. And from there it went to the human beings, and from human beings it became human to human transmission. So that's the hypothesis right now, but things might change. So now let's look at the virus itself. So this is one of the studies they've done on SARS virus. So our new virus is pretty much similar to the SARS virus, so we can pretty much relate to that. So this virus likes to likes the cold temperature better, so 22 to 25 degrees centigrade, and they like the humidity of 40 to 50%. So this is a cold, winter-loving virus, and that's why we can say that usually this virus will have easy transmission during winter, and during summer the transmission should be low, but it's not 100% sure. So um, so we can also see different reports about comparison between SARS-CoV-1, the old SARS virus, versus new SARS-CoV-2 or the COVID-19. So based on different researches, we found that this virus do survive outside in the surface, and they survive from 5 hours to 5 days, or even 8 days. So in surgical gloves, the virus can survive up to 8 hours. In plastic for 6 days. So it does survive in the outside material for a long time, and I think there is some role of temperature and humidity for this survival capacity of the virus. And this is a really difficult virus to cure, to treat, but it's really easy for the to sterilize a surface. Since this virus has a lipid envelope, this can be easily washed out by soap and water, or we can also use ethanol or bleach to disinfect the virus or to kill the virus. So we pretty much talked about the virus, the virology of the virus, how it replicates, and how it came out from the animal kingdom to the human kingdom and all. Now we'll talk about how did the outbreak happen. So the virus actually originated in mid-December from Wuhan district of China. And if you look at the Wuhan district, there's a fish market. So it pretty much came from this area, seafood wholesale market in Wuhan. And also on the other side of the railroad track, there is a virology center, and some people think that the virus leaked out from the laboratory. So we don't know what's true, but those are different hypotheses about how the virus came out. So from Wuhan, the virus actually went to different countries before WHO or China realized that there's a new virus coming out. So most of the countries which had direct international flight with Wuhan, they got the virus first. So that includes United States, um, even Europe, and Indonesia, Thailand, all these countries. And quite surprising that countries in the Middle East or countries in the Southeast Asia like India, Nepal, they didn't have direct connection with Wuhan. So I think that's the reason they didn't have the cases of COVID-19 upfront. And later on, the Chinese government did lockdown in Wuhan, and there was WHO declared global emergency, and the virus. There was a lot of um, processes and projects to control the virus itself. So that's how the virus didn't go to this Southeast Asian countries upfront. So now let's look at the timeline of new coronavirus outbreak. So actually, the virus was discovered in mid-December, and it took a while for China and then the WHO to realize that it's a global emergency. So only in late January, WHO declared global emergency, and within 2 weeks of WHO declaring global emergency, the virus was already pandemic. And as of now, we know that the virus is all over the world, and the only places it's in low numbers are Africa and few other countries, but now it's all over the world. So we can say that the virus went out of control pretty fast and became pandemic. So when you look at the history of pandemic disease in human civilization, this virus is not the biggest one, but it's truly concerning. So this virus has already been more deadly or more pandemic than MERS and SARS, and it might. I think by now it has already reached near Ebola and might go up to this range. So it's getting worse and worse. So now let's talk about how the virus causes diseases in human beings. So if you look at the pathogenesis of the virus, so SARS coronavirus and SARS-CoV2, they pretty much use the same receptor, that is ACE receptor 2, and they also and to bind to ACE receptor, they use their spike protein. And so just like we discussed earlier, the SARS-CoV2 binds to the cell through ACE receptor, gets inside and replicates, and the same process and comes out. So the same picture we're talking about. And once the virus gets into the cell, then it kind of starts replicating. But in the meantime, the immune cells get activated. So the antigen presenting cells presents to different immune cells, and basically the immune cells, they get activated. So they will activate both the cellular immunity and humoral immunity, and they produce a lot of cytokines. So if you look more into it, so there are a lot of different cytokines that gets released. So interleukin 6 is one of them, one of the major ones. And all this cytokine storm, they will cause a lot of inflammation and organ damage. And you'll have liver damage, you have cells dying out, you have myocarditis, you have renal failure, you have a lot of problems from there. And because of this organ damage, you'll get symptoms and signs and symptoms and clinical features based on that. So if you look more, so if you want to summarize about how this virus attacks and causes symptoms, then you can basically divide this in three phases. So in early infection, the virus replicates inside a cell, so it's mainly driven by the virus itself. And in second phase, there's a lot of cytokine storm, and that's because the immune cells get activated. And in third stage, because a lot of cytokine storm and the immune cells become hyperactive, it's not the virus, but it's the immune cells and their cytokines that's causing inflammation and causing damage to the human cells. So we call it early infection, then pulmonary phase, or the in-between phase, and then we have hyperinflammation phase. So people have realized that a lot of people, they die not because of the virus itself, but mainly because of the uncontrolled inflammation that happens after an infection. So in initial phase, when the virus goes into the cells and they replicate and they cause viremia, then you will get fever, some viral-like prodromal symptoms, dry cough, diarrhea, even headache. A lot of things. If you look at the labs, then your cells get used up, so you get lymphopenia, and you might have D-dimer and LDH high. And then there is some kind of inflammation and infection going on in the lungs in the second phase. So you'll have some impairment in respiration. So you'll get hypoxic, short of breath, pneumonia, and you can see that in X-ray or CT scan. And also you'll see some damages in the liver cells. So you'll have all these enzymes go up. And then finally, if the inflammation go out of control, then people die of ARDS or shock or SARS or cardiac failure. And you have a lot of these enzyme markers or inflammatory markers going up, like CRP, LDS, IL-6, D-dimer, ferritin, and also if you have damage to the heart cells, then you'll get troponin leak and BNP elevation. So if you understand the concept of pathogenesis of this virus, then you'll realize that it's not the virus itself, but it's the inflammatory cells causing more problem. So that's why our potential therapies, they depend on the phase of the infection. So in the early stage, your antivirals might work. So you can use remdesivir, or you can use convalescent plasma transfusion. But once the virus starts going out of hand, then you can also use chloroquine and hydroxychloroquine, which are immunomodulatory effect. But once the virus goes out of control and you have more of inflammation, then you can use immunosuppression. So if upfront you want your immunes to be up because you don't want the virus to infect you, but once you are already infected and the immunity is already becoming detrimental to you, then at that point you can use immunosuppressions like corticosteroid, IVIG, IL-6 inhibitor, all this different medications you can try. And also, in 15% of the cases, people get myocarditis or cardiogenic shock, and the reason being that once the virus infects, so the virus uses ACE receptors, and the ACE receptors are found mainly in the lungs and heart. So that's why heart is also prone to infection of the virus from the virus. So people who use ACE inhibitors or ARBs, they are found to have hyperexpression of ACE2 receptors, and these people are thought to be prone to viral infection. So they get more viral infection, and that's why they get myocarditis. But in the same time, this medication like ACE inhibitors or ARBs are protective to the heart. And so some people debate that maybe these medications are protective as well. But whichever hypothesis you believe on, maybe it's the actual infection from the virus itself, or it's the inflammatory cascade that happens after infection. They cause myocarditis, pericarditis, and they can even cause heart failure. And sometimes they can cause ST elevation MI or arrhythmia. So people, they might die of all these heart problems up front in 15% of the cases. So what I want to bring it up here is that it's not only your lungs that's being hit by the virus, it's also your heart that's being hit by the virus. So we spoke about the pathogenesis of the virus. Now, after understanding the pathogenesis, I think it's reasonable to talk about clinical features of the disease. So, if you look at the COVID infection, if you compare the COVID infection with flu virus, then the mortality is pretty much higher than flu virus. So, the mortality of the virus, the flu virus, is less than 1%, whereas the overall mortality of COVID-19 is around 3%. In some countries, it's even more than 3%. So, you can take either way, but it's pretty high. And if you look at the COVID-19 infection itself, then your mortality goes up as as the age goes up. So when people are 50 or above, your mortality is 1.3. But when people are 80 or above, your mortality goes to 15%. So people who are older age, let's say about 60 years plus, they have higher mortality. So your age is against you for the virus. And when you look at when you take out the age as a confounding factor, then a few other things that also increase your mortality. The biggest of them all is cardiovascular disease, 10% mortality, diabetes, chronic respiratory disease, hypertension, cancer, and some other medical problems. So if you summarize that, then you can get a sense that people who are old, they get sick, and people have comorbid disease that decrease your immunity, they are sick. And there's an exception to the rule, that's hypertension. Hypertension literally doesn't cause any immune suppression, but there's a risk with hypertension. And there's a hypothesis. The hypothesis for this is that people who are hypertensive, they tend to use AC inhibitor as one of the most important medications, and maybe that's the reason these people get more infected. But that's all hypothesis, not proven. So let's go back again and let's compare this COVID-19 with a lot of other viruses. So if you look at the SARS virus and COVID-19, COVID-19 mortality is 3%, but the SARS mortality was 10%. So it's less deadly than SARS virus. And if you look at different viruses, then you can see that the SARS virus and MERS virus were even deadlier than this virus. But this virus is less deadly than those two viruses, but it's more deadly than seasonal flu. And I think this slide is really important. So if you look at this slide, you can see that people who are infected with COVID-19, most of the people, like 80% of the people, they are asymptomatic or mildly symptomatic. So they might have just cough, common cold like symptoms, headache, cough, maybe sore throat, and that's pretty much, or maybe mild fever, and that's pretty much. And out of those people, 14% they go into severe cases, so they might get pneumonia and some other complications, so they get admitted in the hospital. And out of that, 5% they need ICU care. That means they usually need oxygen and ventilation and maybe pressors. And the mortality is around 3%, but it also depends on a lot of factors. So that's about COVID-19 itself. And if you look at if you compare COVID-19 with different other viruses, then our this COVID-19, the mortality is 3%. But if you look at other viruses like H1N1, it's less than 1%, so it's deadlier than H1N1. But if you compare with SARS coronavirus, the mortality is 10%, MERS was 35%, and Ebola was 60% plus. So it's not as deadly as other viruses we have seen before. But I'll tell you why this is not as deadly as other viruses, but it's been killing a lot of people. So the explanation is this slide. So when you were designing a really effective bioweapon, you want to design a virus that's high in the mortality, or a virus that's high in the mobility. You know, so if you're high in the mortality, you kill a lot of people up front. But if you are high in the mobility, then you'll be infecting a lot of people up front. And this virus is different. So in a lot of viruses, you'll have this kind of curve. So you'll start people getting sick, They get sicker and sicker exponentially until they hit a flat curve. When you run out of susceptible patients, they hit flat and they go out, But this virus, it's pretty much asymptomatic, and its incubation period ranges from 2 to 3 days all the way to 28 days, and pretty much a lot of patients are asymptomatic. So this virus keeps on spreading in the community until it gets a lot of susceptible people, and then it hits an epidemic. And so that's why people get completely off guard, and that's why a lot of people die. So what I'm trying to say is that this virus has a lot of mobility, and finally it has a lot of mortality once it hits the limit. So it's very deadly. So now let's talk about the clinical features of the virus. So as you know, coronavirus is second most common cause of common cold. So so whenever we used to get common cold, the first was rhinovirus and the second was coronavirus. So this COVID-19 is a form of new coronavirus. So you can expect that this new coronavirus is going to cause symptoms like common cold. So you'll pretty much get headache, malaise, runny nose, cough or sore throat, and even muscle pain. But in certain population, it goes beyond that. So you'll get more complications, like you'll get high grade fever, and then once the virus starts going into your lungs, then you'll have trouble breathing. You might get pneumonia that can go into ARDS, and also you'll have sepsis and septic shock, or even cardiogenic shock. And beyond besides this respiratory symptoms, people present with different other symptoms. Like there are some people who present with diarrhea. So if you look at the numbers, then I think the people who present with diarrhea is 3%. Some people they might present with headache and meningitis. So you might have different presentations, just like in a regular flu. So be wary of that. So so this picture is really important. I think this is from the Lancet, published in January 24. So if you look at the virus itself, then your incubation period is around 5 days to 7 days. So once you get exposed to the virus, then you will start getting symptoms after roughly 1 week, and then within next 1 week, either you get better or you get sicker. So if you look at this time slot, then you can see that usually people get into the hospital within 1 week, and within few days, like 4 to 5 days, they get into pneumonia and they go into ARDS really fast, and they might die. So if you get exposed, then you can expect that you might get symptoms in within 1 week, and if you get lucky, then you'll get improvement within 1 week. If you're unlucky, then you get sick and you might land up in ICU within 1 week. That's pretty much to simplify the course, but it's much more complicated. So people who get admitted in the hospital with COVID-19, they get a lot of other problems as well. So if you look at the CBC, then they'll usually get leukopenia and lymphopenia, 85%, just like in any other viral or rickettsial disease. They might have AKI, they will have some AST, ALT elevation, and bilirubin high. Procalcitonin is usually normal until there is superinfection with bacteria, so this test might be helpful. So usually when you get a patient with COVID-19 in the hospital, you want to do all this test. You want to do pan culture. You want to rule out influenza, because there is influenza going on around, and it's treatable. And depending on your country, you can think about other tropical diseases like scrub typhus or dengue, or TB, and all those things. And also for COVID-19, since it causes cytokine storm and inflammatory problems, we want to check different other parameters like high D-dimer, TROPS, and BNP. Usually these three biomarkers, they are associated with higher mortality. And you can also check on ferritin, CRP, CPK, and LDH. And also you can do SOFA score calculation. Higher SOFA score has been associated with higher mortality. So if you look at the X-ray, then you might have bilateral patchy pneumonia, and it can pretty much go into ARDS. And if you look at the CAT scan, usually you have ground glass opacity. So ground glass opacity, peripheral distribution will be your key finding in the CAT scan. But in some cases, you will have alveolar consolidation, just like in a regular pneumonia. So these two are the major findings. And then if the patient goes into ARDS, then you will have ARDS picture. In some cases, there have been cases with lymph nodes, lymphadenopathy and septal thickening, but those are rare. So the key finding in CAT scan is mainly ground glass opacity in peripheral distribution, bronchiectasis, and maybe alveolar consolidation. So don't be fooled if you just see alveolar consolidation, because it looks like bacterial, but it could in fact be COVID-19. So this is a courtesy from MGS. So they're pretty much divided patients uh, category in as per the risk. So if you have any of your patients with this risk factors, then your patient might need an ICU and might get bad. So I'll just read it out. If you are more than 55, you have pre-existing pulmonary disease, CKD, diabetes, hypertension, cardiovascular disease. If you're using biologics like in autoimmune problems, if you have transplant or you are on immunosuppression, or all patients with HIV, regardless of the CD4, you wanna keep them in the hospital and want to be watchful on them. And besides that, vitals wise, if you have respiratory rate high, heart rate high, your sats are down, and if you look at the labs, if your D dimer is very high, if your CPK is high, CRP, LDS, troponin, absolute lymphocyte count less than zero point 0.8, or if ferritin very high. So pretty much what I spoke to you about. So if you have all these biomarkers positive, then you pretty much need to worry about your patient and be watchful, and pretty much take them to ICU. So we spoke about the clinical features of the virus. Now we'll talk about diagnosis of the disease. So whenever a patient comes to you with these features, then you pretty much want to follow WHO, or you want to follow your CDC guideline, depending on which country you have. So I'm talking about people in Nepal. So in Nepal, we had this guideline few weeks back, but I think we're going to update that, and there's a new guideline from NMC. So please follow that. So pretty much the important thing is that if you have any patient in your hospital with ARDS or upper respiratory tract infection, pneumonia, or ground glass opacity in CAT scan, always rule out influenza, and then always think of COVID-19. So now let's talk about our testing criteria in Nepal. So the new criteria is that any patient who comes to your hospital or fever clinic, you want to throw out these screening questions about symptoms, and most important, you want to question about their travel or exposure to people who have traveled, and you want to check their temperature, and then let's put it there. So I'm making it simple for you guys, so so basically, any patient who presents with fever plus cough or shortness of breath within 14 days of returning from outside of Nepal, or people who have been in close contact with someone who has come outside of Nepal in last 14 days. I think it's self-explanatory here. And besides those people, you also want to put people who are healthcare workers, like doctor or nurses who work in a hospital, as high risk people. So if doctor or nurse or any people who've been in the hospital get fever or cough or shortness of breath, you want to check them out. So the very important thing here is that you don't want to wait for these high risk people to get cough or shortness of breath. If people who are working in the hospital, they get fever, you want to make sure that they don't have COVID-19, because if you miss that out, then they might transmit the virus to other people. So that's why it's very important. So that's the key difference between people who are healthcare workers versus people who are public. And in any other cases, people who are admitted in the hospital with infiltrates or ground glass opacity or ARDS, and you have pretty much ruled out other alternative diagnosis, you want to think of COVID. And people who are not in the hospital, they are in house, but they are having fever plus cough or shortness of breath, and you checked out for influenza and some other etiology, but those been negative. In those patients, you want to think of COVID-19 and you want to check them out. And besides that, the government has their own policy to check randomly on samples collected for influenza. So also you need to know who do you consider close contact. So a close contact is a person who has experienced any of the following exposures during the 2 days before or 14 days after the onset of symptoms of a confirmed or probable case. So if you are working in a hospital, if you have direct physical contact, that's positive contact definition. If you are in a hospital or in house taking care of the patient without proper personal protective, then you are a close contact. Or if you are taking care of you're face to face with somebody and have spent more than 15 minutes within 1 meter without using proper protection, then you are a close contact. So remember, the take home point is 15 minutes and 1 meter, within 1 meter. So once you have somebody in your hospital and we suspected with COVID, then you want to admit them, you want to isolate them, and then you want to do a test. So usually in Nepal we do PCR test to diagnose. So if the patient is not intubated, then you prefer nasopharyngeal swab and or oropharyngeal swab. But if the patient is intubated, then tracheal aspirate is better, is the most sensitive. So you want to send this. So we'll talk about the role of serology in Nepal, and also you can pick up virus in urine, stool, and blood, but we don't do those tests here. The take-home message is that this virus has been found in stool and urine, so there is always a risk of this virus getting fecal-oral transmission. So that factor has to be considered if you are isolating somebody or if you are putting somebody in quarantine. So now we'll talk about who to admit. So as of now, we admit any patient who is suspected of COVID-19 or who is proven COVID-19. But later on, if we get an outbreak, then there's no way we can admit all the people. In that point, we'll have to prioritize the patients. So we'll only admit people who might get sicker, and you don't want to send them home. So if you look at that, then people who are already sick, who got pneumonia, who are old age or pregnant, are a lot of these risk factors. You want to admit them. And some people, they also propose that people who have D dimer more than 1 micro per ml, they are high risk. You want to admit them. But if you are not admitting somebody, then later on when you have an outbreak and your hospital beds are full and you don't have any beds left to admit somebody, then at that point you might have to send the patient back home on self isolation. So at that point you should take contact number, address, and next of kin contact. Send the patient home in a personal vehicle and ask the patient to wear surgical masks. And ask the patient to be in self quarantine or isolation, and call back for report. These are things you need to do, and there's also criteria to send patient home if they are stable enough. And there's also a guideline from NMC about how to transfer a patient from one center to another. The main thing is that patient who is getting transported, they will have to wear a face mask, and people who are transporting will also have to wear a face mask unless the patient is using NIV or intubated or getting bag and mask, in which case there's risk of aerosolization. So the people who is involved in transporting the patient might have to use N95. So we'll talk more about this. So we'll take a short break, and we'll talk more about the isolation and infection control. Any questions are more welcome here. All right, thank you very much for the patience. I'm back, and we'll talk more about isolation and infection control. And if you have any questions, you can write me up. I don't see any new questions, so we'll move ahead. So let's talk about how to do. So somebody's asking what's the exact incubation period. So the mean duration is 5.2 days. So you can say pretty much 1 week, but it can range all the way from 2 to 3 days to a maximum of 28 days. So I hope you got your answer. So we'll move ahead with isolation and infection control. So in this topic, we'll talk about once you admit somebody in the hospital, then how do you want to isolate the patient and how do you want to control the infection from spreading from one patient to another. So before we move on, we need to understand about the surgical mask. The surgical mask we use has actually 3 layers, and the middle layer is actually a filter, and whenever you're using a surgical mask, your outer layer, which is hydrophobic, should be kept outside, and usually the outer layer is in green or blue color, so you want to always keep your mask with green or blue color facing outside, and your inner layer, which is water absorbent, you want to keep it inside, so usually the white layer should be inside. And there's another mask is called N95. It comes with different size and shape, and also different names. So basically they can come with different names, like somebody can call it N95. If it's made in China, they call it KN95. If it's European standard, they call it FFP2, and sometimes people call it 3M. So no matter what's the brand and what's it's called, if you have any confusion, you always want to check the company and check the authenticity of the company and the mask in Google, so that you know what you're using. And so the difference between N95 and surgical mask are few. So in surgical mask, whenever you wear the mask, it doesn't have to be airtight. But on the upper side, there's a metal bar. You want to fold it as per the shape of the nose, but it doesn't have to be airtight. But whenever you use N95, the idea of using N95 is to prevent aerosolized virus, which are very small. So if you're using the mask, you have to make sure that it's airtight. So to make it airtight, you don't want any facial hair. You want to be clean shaven, no facial hair. And once you put on your mask, you want to make sure that it's airtight. There are a few ways you can do. One is that you put on your mask and then you suck the air in. The mask should shrink, and then you blow the mask. It should swell up, or it could be puffy. So if it shrinks and it becomes puffy, then you know that the mask is airtight. If it's not airtight, then it's not 100% protective, and that's very important. And no matter which mask you use, N95 and surgical masks, depending on the procedure, they're equally effective in protecting from viruses. And the other mask, like cloth mask or sponge mask, nobody knows, but they are not that protective, but you can use them if you don't have any. So let's move on. So if you're working in the fever clinic in the OPD, or you are in the triage room in the emergency, then if you are getting COVID patients, then always see them in a separate isolation room. And as soon as the patient walks in, then give the surgical mask to the patient, have the patient follow cough etiquette, keep the patient 1 meter or 3 feet far, and the healthcare worker himself or herself should be wearing a surgical mask, and don't forget to wear goggles or face shield, and also gown. And usually you don't need to wear N95 unless you're collecting sample, and that's very important. So if you're only seeing a patient but you are not collecting sample, then you don't need to wear N95. Besides that, you need to follow hand hygiene, and also you don't want to touch your mucosal membrane with your hands. So your mucosal membranes are nose, mouth, and even eyes. So when you talk about this, I want to bring this up because people should know how the virus gets transmitted from the sick patient to other people. So whenever a patient is coughing or talking or even sneezing, then the virus gets into our droplets, or the respiratory secretions, they get into droplets which are very small, but we cannot see them with our eyes. And this droplet, they can travel up to 6 feet or 2 meters distance. And if you are within 6 feet or 2 meters, then these droplets can land in your mouth, your nose, or your eyes, and the virus gets in. So whenever you want to prevent yourself from getting infected, you have to wear a mask, and also don't forget your goggles or face shield. And more important than that, there's another very important mechanism by which the virus gets transmitted. That is, the patient, whenever they cough or sneeze, the virus comes out of their respiratory mucosa. They travel in the droplets and they land up in the surrounding areas, like it could be tables, chairs, sofa, or even laptops. And then when the next person comes in, they put their hand on the surface, they get the virus in their hand, and later on they transmit it to themselves or to others. So that way of indirect transmission of virus is called transmission through fomites, and that's also very important. And that's why, besides your mask and your goggles, it's equally important to maintain a safe hand hygiene. And there's a third category by which the virus can get transmitted, and that's called aerosolization. So I'll talk about it right away. So there are few procedures in which the virus can get converted into aerosols. The procedures are usually done in emergency or ICU, and people who work in the emergency or ICU, they should be aware of that. So the procedures are as follows: nebulization, intubation, invasive ventilation or non-invasive ventilation, open suctioning, extubation, and CPR, or procedures that involve ENT and lungs. ENT procedure, dental procedure, upper GI endoscopy, tracheostomy, and bronchoscopy. So in only these procedures, the virus gets aerosolized and your surgical mask is not going to work. So especially in these patients, you have to wear N95. And not only that, you have to keep these patients in a separate isolation room, which is called negative pressure isolation room, or equivalent to negative pressure isolation room. We'll talk more about that. So, so remember, whenever you are admitting this patient in the hospital, any patient who is suspected of COVID-19, they should not be mixed with patient who is COVID-19. So you don't want to mix suspected cases with proven cases. That's very important. And let's talk about PPE, or personal protective equipments. It consists of mask, gloves, goggles, eye shield, gowns, shoe cover, hair caps. So rooming is very important. So we prefer individual room for individual patient. But if you have a lot of patients and you don't have enough room, then you can do cohorting. It's called keeping similar patients together. So whenever you doing cohorting, you are keeping more than one patient in one room. But make sure these patients are 6 feet apart, if not then at least 3 feet, and they are wearing surgical mask. And after seeing each patient, you have to use soap and water, or you have to do hand sanitization, and each patient will have their own equipments and sanitizer at the bedside. So patients who are admitted in the hospital and who are not sick, they can be managed by droplet or contact precaution. When you talk about droplet and contact precaution, then you want to wear a surgical mask, you want to wear goggles, you want to wear gloves, and then you want to wear a gown. You don't need N95, and the room doesn't have to be spatial. But as I mentioned earlier, if you have this kind of patients who are very sick and you're doing these kind of procedures or this kind of surgeries, then this patient will generate virus in the air. That's called aerosolization of the virus. So especially in this patient, you want to use N95 mask. And also, you want to keep these patients in a spatial room, not in a regular room. So the equipments, the PPE you want to wear is N95 mask, and pretty much the same thing like before, like goggles, gloves, and gown. And when you talk about the room for this aerosolization generating patients should be negative pressure room. But if you don't have a negative pressure room, then you can set up this kind of room, which is called unilateral laminar flow room as per WHO. So pretty much you have a room where you shut down all the doors and windows, and on this side, which is facing the outside, you want to keep exhaust fans. You want to keep your patient here, maybe the bed or the table here, and this is your door. You enter from here and you're here. So the whole idea is that the air always flows from door to you to the patient, and the virus containing air is thrown out or blown out by the exhaust system or the fans. So if you can maintain this kind of system, then it will be pretty much equivalent to negative pressure isolation room. And while intubating a patient, there are a few things you need to remember. You want to So during intubation, there is a high risk of aerosolization. So you want to always make sure that it's very quick. If you have equipments, you want to make it through a bronchoscope or a videoscope. If you don't have it, that's okay. And to make it quick, you want to use muscle relaxant. And second important thing is that you don't want to do bag and mask. You don't want to bag the patient, because if you bag the patient, there will be aerosolization. So no bagging. And also some people, they kind of plug this ET tube, or to prevent the virus from coming out. And if you have a viral filter, you can use a viral filter. So these are things you can consider while intubating a patient. So if you want to learn about how to use PPE, you can follow the link, or you can visit the WHO site. So if you have any question, you can throw it up, but if not, then we'll move on to sampling and transport. I guess not. So let's talk about how do you collect the samples. So as I mentioned earlier, for non-intubated patients, in adults, you want to do nasopharyngeal, which is preferred than oropharynx. The reason being there is less aerosolization, but doing a nasopharyngeal sampling is very tricky, because if you haven't done it, then you may not know it, because a lot of people end up doing sample from the nose instead of nasopharynx. So when you do nasopharynx, you have to go beyond the turbinates and you have to hit the nasopharynx. So you can measure the distance from the earlobe all the way to the nose, and go up to 70 to 80% of the distance. Then you'll hit the nasopharynx. Or you can do oropharynx. For children, you can do nasopharyngeal wash. And remember, if you are somebody who is taking the sample, then you always need to wear N95, and also you want to use face shield or goggles. But if you have somebody who is already intubated, then the best would be intobronchial tube aspirate. Or if you're doing bronchoscopy, which is not recommended, you can send the sample. And you want to put the patient in a viral transport medium, and the viral transport medium has to be maintained in a cold chain of 2 to 8 degrees centigrade. You don't want to freeze it, and you don't want to send the sample in room air. That's a blunder. And now let's get into this slide. I think this is very important, because this will make you clear about PCR based test versus serology based test. So if you look at the slide here, then if you look at the SARS coronavirus RNA or antigen, then as soon as the patient becomes symptomatic, then I think the symptoms are coming from here. Even before the symptoms onset, you'll start getting the antigen or the RNA, and pretty much around 7 day of infection, you will get IgM, and a week later you will get IgG. As soon as you start making IgG, then your antigen goes down, or your RNA goes down. So what I mean is that in the initial first week of infection, PCR is the best. From at the end of first week, within 14 days, You can combine PCR with IgM, and after 2 weeks, serology is the best. And if you look at if you look at the PCR itself, then the PCR depends on viral load. So the viral load also depends on the sample site. So I think if you look at this table, then if you're doing RT-PCR, the best sample should be sputum. Once patient has pneumonia, sputum would be the best. If not, then you can do nasopharyngeal swab or even oropharyngeal swab, And a few other things you want to note here is that they found virus PCR positive in stool, anal swabs, and rectal, and even in stool. So that means that there is a risk of fecal transmission. They have also found in blood. So in viremic phase, if you're doing transfusion, blood transfusion, then there's a risk of virus transmission through blood. But surprisingly, it's not found in urine, and also it's not found in vaginal swabs. So it's not STD, or it's not transmitted sexually, as far as we know right now. And I think this slide is very important. This slide is from Zhao et al. Clinical Infectious Disease, published recently. So they pretty much compared all these different testing strategies in 173 patients. So if you look at the initial 1 to 7 days, I think the most sensitive is RNA PCR. The serologists, they are least sensitive. But if you combine them all, your sensitivity goes to 78%. So what I mean is that we usually do RT-PCR in first week of symptoms, but you'll miss a lot of patients because it also your sensitivity is not that great. After 1 week, then total antibody, preferentially IgM, is most sensitive. Your RNA drops down to RT-PCR drops down to around 50%. But if you want to get the best out of them all, you want to combine them all. And after 2 weeks, your RNA drops down less than 50%, but your IgG goes up and IgM stays more. So if you want to get 100%, you want to combine, or you want to get serology. So the bottom line is, if you have somebody in the early who is symptomatic and is in the early phase, if you have to choose one test, you want to choose RT-PCR. But if you have luxury, you can combine them all because your combined sensitivity goes up. After 1 week, you want to do serology, and beyond 1 week, you just want to do serology. So I think that will make things clear. So my proposition is, in case of symptomatic patient, if it's within first week, you want to do PCR. Second week onwards, you want to do PCR and serology. But if they are beyond 2 weeks, you just want to do serology. But if you have resources, we can combine PCR and serology because that will increase our sensitivity. And if you have somebody who has pretest probability is very high, but your test come negative, you just want to repeat it, because even if you do RT-PCR, your sensitivity is not great. So if you think somebody is infected, but your RT-PCR comes negative, you just want to repeat it again. And if you're talking about patients who are in quarantine, then if they are not symptomatic, you prefer serology. And if they have higher pretest probability, you just want to repeat the serology. Example, people who are exposed to a sick patient. And if they get symptomatic, you want to follow this protocol. If you want to check for patients who are in hotbeds, then the best would be to combine both the PCR and serology test. That will increase your sensitivity. And if your test come negative or your pretest probability is high, you want to repeat it. And the most important thing of them all is that influenza is also endemic in Nepal, and maybe it's endemic in your area. So always rule out influenza before looking for COVID-19. So I hope if there's any question, you can ask me here. If not, then we'll move on to treatment. So let's talk about treatment of COVID-19. So this is a complicated flow chart from NMC about how to manage COVID-19 patients in hospital. So pretty much it summarizes the things I told you. People who are sick, who fulfill the criteria, you want to check them. And if they are mild, you want to just isolate them. If they are very sick, you want to admit them in the hospital or in ICU. And in very sick patients, even if they are negative, you want to keep them isolation and retest. So these are the things you can read about it. But let's move on to our guideline. So basically, treatment of COVID-19 is really complicated. So you need a team of effort. So basically, you want to have a team of experts in each hospital. The doctors involved should be ER, ICU, internal medicine, infectious diseases, and anesthesia, and infection control nurse, microbiologist, administration, housekeeping, and engineers. So and also you have to remember this, that all the patients mentioned here, they are high risk patient. So if anybody who is suspected of COVID-19, these patients should be admitted in the hospital even if you don't have many beds. And WHO has classified COVID-19 clinical syndromes into mild illness, pneumonia, severe pneumonia, and ARDS, which is pretty much consistent with the regular terminology. And also they have sepsis and septic shock. So regarding treatment, as of now, WHO has not recommended any antiviral medication. They are in the trial, but nothing is proven yet. Um, and so there's only symptomatic and supportive treatment. Target sats more than 90 should be enough. But if you have somebody who is pregnant, you want to maintain more saturation for the fetus. So your target saturation might be 90 to 95%. And WHO says avoid steroids and avoid over-aggressive IV fluids. And of course, vaccine is on trial, but we don't think it's going to come out really fast. It might take 1 year or more. So this is the US guideline for antiviral treatment. So in United States, they've been using remdesivir. That's a drug that was used in Ebola and made by Gilead. But they have a strict policy for the medication because they have a lot of exclusion criteria. So basically, they are using remdesivir who has purely pulmonary problem and don't have any other multi-organ dysfunction. So if you're intubated, you have pneumonia or maybe you have ARDS, but you don't have any multi-organ failure, then you might qualify for remdesivir. But they have pretty much included patients from United States and South Korea. So the next best option, as per United States, has been hydroxychloroquine, and also people have tried HIV medication in some patients. So let's look over our guideline. So basically, in Nepal, what we can do is that whenever you admit a patient with suspected COVID, you also want to treat for bacterial and other atypical bacterial infection or even influenza until proven otherwise. So I think your antibiotic of choice should be vancomycin with ceftriaxone. You might add azithro or doxycycline for atypical coverage, and you also want to add Tamiflu until you rule out influenza. And people have found that statin has been beneficial. So if somebody qualifies for statin, you can start it. It's not antiviral, but it's immunomodulatory. And as per NMC guideline for Nepal, the proposed treatment would be hydroxychloroquine, or you can also do chloroquine. And if those are not there, then it's option B, but it's not in the guideline. Some people have tried ART medication, lopinavir, ritonavir. I think there's been a recent publication that there's no benefit, but in a subset analysis, they found benefit if this ART is used early. So if you don't have any option, you can use it. So let's talk about hydroxychloroquine and chloroquine. So this medication, they can be used, but the thing is that you should be careful because the contraindication is mainly heart failure or QTc prolongation, and also people who have non or suspected G6PD deficiency. So and if you don't want to start this medication and forget about EKG, because you have to monitor QTc every day. And a lot of these people who are placed on hydroxychloroquine, they also get azithromycin or other medication which prolong the QTc. So that's been the biggest problem. So if you put somebody in chloroquine medication, make sure that you check on QTc and make sure they are not heart failure patients. And regarding G6PD deficiency, if you have resources, of course you can do G6PD deficiency test. But if you don't have resources, then it takes time to get the report back from the lab for G6PD level. So it's not advised. You just want to use it upfront. Option B, some people they use lopinavir ritonavir, but I told you it's been controversy, and especially if you want to use this medication, you want to make sure that they are not HIV positive. You always want to check that, because if they are really HIV positive and you only use this medication, then your HIV will get resistant, because that's a partial treatment for HIV. And also this medication, they are hepatotoxic and they cause lactic acidosis. Some people they have also used darunavir and cobicistat. And option C could be anti-interleukin 6, interferon, or antiserum antibody. So in the Western world, in the developed world, this anti-IL-6 has been hugely popular. So if you look at the pathophysiology, then in the second or third stage, the immune system has a bigger role in the pathogenesis of the disease. So if you think somebody is having cytokine storm, then you can use anti-IL-6. Tocilizumab is one of the medication used for that, and there's a criteria for using tocilizumab. And always make sure that you want to send IL-6 level and other markers before you use anti-IL-6. So those were antiviral and some other immunomodulated medication that can be used. Now let's talk about a few other things. So as soon as you have a patient who is COVID positive, then you want to taper off antibiotics. Usually you can take out Vanco and Tamiflu if they are negative. Avoid steroids. Even you want to avoid inhaled corticosteroids, except absolutely needed, like septic shock or adrenal crisis. The reason is that this is a viral disease, so we need immune cells, especially T cells or cytotoxic T cells. Steroids will decrease your immunity. So if you use steroids, then your virus will go out of control, and also that will increase viral shedding. And also there is no effective antiviral medication, so you don't want to use steroids. You want to avoid NSAIDs. If the patient has fever, use acetaminophen. And there's a lot of debate about patients who are already in ACE inhibitor or ARBs. So the current recommendation is that if somebody is already on this medication, let them continue, but you don't want to start fresh on your new patients with hypertension or any other indication. You don't want to start right now when there is a probable outbreak of COVID. But if somebody is already on this, you can just continue. So your patient might present with shock. If the patient presents with shock, then consider a few things, like it could be superinfection, it could be cardiogenic, or it could be hypovolemic because of third spacing. And so any viral infection can have superinfection, but the rate of superinfection in COVID-19 has been found really low. So a lot of people, they do procalcitonin upfront, and if the procalcitonin is not that high, they don't worry much about bacterial infection. And in 5% of the cases in severe COVID-19 infection, they have found secondary HLH syndrome or hemophagocytic lymphohistiocytosis. So if you consider somebody to be having HLH, you want to pay attention to cytopenia, organomegaly like hepatomegaly or splenomegaly, lymphadenopathy. So usually if you have just a COVID-19 infection, then you might get leukopenia, but usually you don't get all this organomegalies or lymphadenopathy. So if you have a sick patient with COVID-19 and they start getting organomegalic or lymphadenopathy, and they have cytopenia, then you need to worry about HLH, and you need to check for markers. The markers we can check are ferritin, high triglyceride level, and hepatitis. And also you can follow this link. There's a scoring system. You want to follow this link and put all your data there, and that will give you a hint about if this is a probable case of HLH or not. If it's really an HLH, then that patient will benefit from steroids, and you might have to start on methotrexate and etoposide. So you have to call an expert for that. And also in COVID-19, you don't want to give liberal fluid. You just want to go for conservative fluid management. So so the sepsis guideline for ml per kilo body weight may not work. You have to go for as per individual clinical judgment. So you can do passive leg raising test, bedside ultrasound, flow track, and a lot of other things to fine tune the fluid requirement of a patient. And other possible options, ivermectin has shown a really big impact in vitro data, but we don't have any animal module or human module for that. So it might pan out as one of the game-changing medication. Some people, they have used leflunomide, which or even thalidomide, which have immunomodulatory potential. So basically, they work in stage 2 or stage 3 of the infection. Antiserum could be is on trial and it might work. So I recommend that all the patients who are PCR negative and IgG positive, we should maintain a database of them, because if we really get COVID-19 outbreak, then we might be able to use their serum for our patients. And besides that, there are a lot of anti-influenza medication, monoclonal antibodies, CAR therapy, and also I spoke about fusion inhibitor earlier. And I think there are some promising medication from Ayurvedic, like turmeric and ginger. Um, and also people talk about antioxidant vitamins like vitamin A, B complex, vitamin C and E, and vitamin K, and also minerals like selenium, and copper. You can use, and some people have hypothesis on that, so maybe you can try. And this is my own personal recommendation, because right now we also have influenza endemic in Kathmandu and other parts of Nepal. So you just want to protect yourself or your people from those viruses. So I strongly recommend vaccinating yourself or your people with influenza vaccine and also pneumonia, because a lot of these old people, they also die with influenza, or they also die of pneumonia. So you better think about those diseases and also vaccinate your patients. And also there's a new trial going on. So they think that there's less severe cases in Southeast Asia region because we use BCG vaccine. So we don't know if it's going to work or not, because a lot of people, they ask about using BCG up front. So I have some feelings about it. The thing is that if you use BCG right now, maybe it would help to prevent a viral infection. But if you ultimately get an outbreak, if you get infected with the virus, then your immune cells going to be hyperreactive. And we've already learned that your hyperreactive immune cells are the reasons people die. So BCG vaccine might be counterproductive if you use it right now. So maybe if you had used it like months before, then you would have been safer. But right now, when we are almost having an outbreak, I don't think it's a good idea, because it might just make your immune cells hyperreactive, and once you get an infection, you might die of that problem. So I don't think it's a good idea, but you can try. And now let's talk about patients, COVID-19 patients to be managed in ICU. So, there's so people in the developed countries, they prefer early intubation rather than going for a non-invasive mechanical ventilation. For example, you want to put the patients on who are hypoxic. You want to give them FiO2 and increase on FiO2. You want to keep them on Venturi and non-rebreathers. And if they fail that, usually your next step would be to put them on BiPAP or some non-invasive mechanical ventilation. But this non-invasive mechanical ventilation or BiPAP causes aerosolization of the virus, and there's risk of spreading the infection to others. So in the developed world, like Europe or United States, they are against BiPAP or non-invasive ventilation. So any patient who fails oxygen therapy, they straight go for intubation. But I think in developing world, we don't have that luxury. We don't have ventilators. So I think we should give a chance. So we should go for non-invasive ventilation or BiPAP, but make sure you put the patient in negative pressure isolation or unilateral laminar flow, and also you yourself use N95 and goggles. And when you intubate somebody, as I mentioned earlier, you want to make a quick intubation. um, you want to use paralytics. You don't want to do a bag and mask and those kind of things. And some people, they have also tried awake proning before intubation. You put the patient flat on their belly, and if they improve, fair enough, you don't need intubation. So I would say, if you have somebody, go for supplemental oxygen, then for non-invasive ventilation, then do awake proning, and if they fail, then you go for intubation. And you don't want to do resuscitation on a patient, because when you do CPR, there's a lot of aerosolization. There's no point doing CPR, so I'm against it. You don't want to do nebulization. You want to do MDI rather than nebulization, and you want to limit the entry of people into the ICU. So you just want to do elective blood draws or test. And also, a lot of people, they don't want to do CAT scan because that's a risk for others for spreading the infection. And you want to restrict visitors to the ICU. And the last thing is that you want to cohort all the patients in one particular area of the hospital. And if somebody is interested in self-proning of awake non-intubated COVID patients, then you can pretty much follow this algorithm. I found it really useful. You can try this. You can take a screenshot, I think. So you can try that, right? Okay. Now let's move on to the next slide. So let's talk about persistent hypoxia or ARDS patient. So people have found two kinds of structural patterns in CAT scan on hypoxic patients with COVID-19. So in one pattern, people only have some ground glass opacity, patchy pneumonia, but not that much. But it's still their PA-FiO2 ratio is 95. Whereas in other patients, there's full-blown ARDS. It's really like ARDS all over. And as expected, your PF ratio is low. So this CAT scan correlates well with this PF ratio, but this CAT scan doesn't correlate well with this PF ratio. So if you look at the Hounsfield units, then this is more aerated, and it's not that wet lung, whereas this CAT scan or this lung is less aerated and has more water in it, or more weight. So there are two patterns of hypoxic ARDS type lungs in COVID-19. This one is called type L, and this one is type H. In type L, there's low elastance. That means there's highly compliant lungs, but there's problem with perfusion and ventilation. So there's some problem with the perfusion of the perfusion mechanism of the lungs. Whereas in this variety, there's high elastance. That means there's low compliance, and the patient are hypoxic because of shunting. And this is your peculiar ARDS patient. So if you have somebody with this kind of picture, you don't want to intubate up them front. You want to go with increasing FiO2. Or if you have already intubated them, you don't want to increase the PEEP. You just want to increase the FiO2. Or some people, they have also tried hyperbaric oxygen therapy in this kind of patients. But if you have somebody who is already in ARDS, you want to follow ARDS protocol. And sometimes people who are in type L, they can go to type H. So you might have to check on their chest x-ray or look at the lung compliance. So a lot of things up in the air, but now you know that there might be two varieties of ARDS or CAT scan finding in COVID-19 patients. And the reason the patients are hypoxic may be totally different pathophysiology. And if you are interested in managing a ARDS patient, then you can pretty much follow the ARTSNet criteria. So you have this Berlin's criteria to follow to adjust to make sure that your patient is ARDS or not. Make sure that the patient don't have cardiogenic shock, because a lot of these COVID-19 patients, they also get a myocarditis and cardiogenic shock. So you just want to rule them out by echo or some other mechanism. And if their heart is good, then you can pretty much go in favor of ARDS, consistent with your chest X-ray finding. you can calculate your ideal body weight, so you can pretty much look at the table. So so this is there are two tables in ARDS. People who are in severe ARDS, you want to go for higher PEEP and lower FiO2, this table. And people who are less sick, you can go on this table. But as a practical point of view, a lot of people, they go for PEEP of 10. They start with PEEP of 10 and FiO2 of 70%. And also, they whenever somebody is getting FiO2 of 70% and requiring PEEP of 10, they prone them right away. That has been helpful. And also, they might have to paralyze the patient. So proning and paralyzing the patient might be helpful. And once you intubate a patient and you set up your PEEP and targets, you want to target for plateau of less than 30. And there are a few ways you can do. You can first decrease the tidal volume. If that doesn't work, then you can decrease more by 1 point. There are a lot of things you can do. And some people, they also would go with the driving pressure, but I don't think it's proven, but you can try. So so in ARDS management, you allow for low tidal volume and high respiratory rate, but the patient will get high amount of CO2 or carbon dioxide. You call it permissive hypercapnia. So if you get a lot of CO2 in your lungs, then your pH will go down. But as long as the pH is, I would say, more than 7.15, I think it's okay. You don't want to worry too much on that. If it falls more than less than 7.15, then first you can start increasing your tidal volume. If not, then you can use bicarb drip. You can sedate the patient more. You can do paralysis. You can do a lot of other things. So I think this kind of things get really complicated. So you better seek expert help. And also, if all these people fail, then people can try ECMO. It really works well. And also ECMO, if you do ECMO, you can also bypass your heart depending on which type of ECMO. So if somebody has ARDS and cardiogenic shock, you can go for ECMO right up front. So to summarize, if somebody is already in ARDS, you just want to go for PEEP of 10, start with FiO2 70%, prone and paralyze them, and play with your ventilator to get a lower plateau pressure. And depending on your pH, you might have to play with the tidal volume, or you might have to start bicarb drip, or a lot of other things, and also think about ECMO. And I think this is a slide about CPR on COVID-19 patient. But I recommend against doing CPR because it's futile. The patients are really sick, and also there's a really high risk of transmission of the virus to the healthcare workers. So I'm totally against it. But make sure if you're doing CPR, the patient has to be in negative pressure isolation room. Okay, so so you manage the patient in the hospital. But the patient got better. Now you want to discharge the patient from the ICU. So this criteria for discharge from the ICU: if the patient is hemodynamically stable for more than 8 hours and off ventilators for 24 hours, you can discharge the patient out of the ICU. And this criteria for the patient to go home, your criteria is that the patient should be off fever more than 3 days, and improvement of the signs and symptoms, and been 7 days since the last initial symptoms. And also, before you send home, you want to make sure that they're not shedding their virus. So you want to do a PCR test, at least 2 tests 1 day apart. So this is very important. Okay, and now we're coming towards the end, so we'll talk about people who are COVID positive and they are in home isolation. They should be in home isolation for 2 weeks, and they should be wearing surgical mask. Okay, for healthcare workers, if you're taking care of COVID-19 patients, then you need to make sure that you don't carry the virus when you go back home, or you go back to your residency or place where you live. So all in your hospital, you always want to mark a safe area and a red area where there could be infection. So once you come out of the hospital, then you want to take off all your clothes and dump them for washing in hot water with soap and water, or even autoclave. You want to make sure that your gadgets like phone and everything is sterilized. And then you want to take a shower, full-blown shower, with soap and water, preferably hot water. and then put on new clothes, and then you are out of the hospital. So you need to set up a system like this so that you don't carry the virus with you when you come out of the hospital to your home or to your other place you live at. Now, finally, we'll talk about epidemiology control of the virus. So, if you want to control the viral outbreak, then we pretty much follow this curve. You want to flatten the curve, So, if you look at the curve, if this is the number of ICU beds, if you get an outbreak, then you'll run out of the ICU beds. So, what you want to do is you just want to you might get the same number of sick patients, but you want to delay them having coming all of them at once. So that's called flattening the curve. So the population of Kathmandu is actually 2.4 million, and if 5% of them need ICU, that's going to be around one and a half, 1.5 lakhs, I guess. So the point I'm trying to say is that our existing health system cannot cannot take care of the sick patients if we get an outbreak. So rather than having an outbreak, we should go for prevention, and the only way we can prevent is social distancing, um, testing, surveillance, and all those uh, epidemiological measures. So the R naught scale of this virus is 2.2. So if you look at the 2.2, one virus is going to transmit 2 to 3 patients. The only way you can prevent this is that you want to maintain social distancing. If you maintain social distancing, then the virus will be able to infect less people. So instead of infecting 406 people in 30 days, if you really follow the rules, then in 30 days you'll be only infecting 2 to 3 people. So social distancing is the only way you can prevent the spread of this virus until we have a vaccine or treatment. And also the duration of lockdown or everything depends on your epidemiological risk, the number of susceptible patients, the number of tests you can do, and a lot of other things. So this is the data from India. So you can look at the graph and you can say that lockdown can effectively prevent prevent from big outbreak, but it cannot really prevent an outbreak. It can only slow it down. So you have to be really be thinking about this. So lockdown is not the answer, but it's only a way you can slow down the outbreak so that you can use other things to really control the disease. That's what I meant to show it here. And so in Nepal, as of now, we've been only waiting for the sick patients to come to the hospital, but I think our strategy should change. We should go from patient coming to us to we going to the community and finding the sick patients. So these slides are actually borrowed from Dr. Archana from KUMS, and I thank her very much for this, and she can explain it more better. And so there are countries who've been able to flatten the curve. So when you are not being able to control the virus, the curve will be exponential, so it will follow a straight line. But once you are able to control the virus, then it will follow this flat line. So countries which are flat or which have less slope, they are countries who are doing better to control the virus. Okay, and I do get a lot of questions about how to use PPE, how to reuse PPE. So there are only few studies about that. So if you go about the studies, so I'm talking about the facial mask and maybe N95. I think the best one is hitting the mask in 70%, 70 degrees centigrade hot air oven for 30 minutes, or UV light. We don't have all these things. So the second best would be microwave at 70 degrees centigrade, but make sure your rubber band doesn't get melted away. The fourth thing is that you can dry them up in sunlight, because sunlight has UV rays. And there have been some people in Taiwan who have tried a pressure cooker for a few minutes to sterilize the mask. So none of them have been proven, but you can try. And WHO has recommended, if you are using N95, you better use a face shield so that it prevents from a lot of virus sticking to your mask. Or if you don't have a face shield like this, you want to put on a surgical mask in front of your N95 so the virus doesn't stick to your N95, and you can decontaminate the N95 easily later on. And finally, we'll talk about some myths. So some people think that a new coronavirus cannot be transmitted in hot areas, but that's proven wrong. It still gets transmitted in hot and humid climates. I think it all depends on your population density, how closely people are connected to each other. That's the main criteria. And I'm sure the virus survives less when it's summer, but it's not going to slow down. So I think you might be able to slow down the transmission, but you're not going to prevent transmission even if it's summer. And hot bath has not been shown to prevent the new coronavirus infection. Spraying alcohol or chlorine all over the body doesn't kill the coronavirus, because coronavirus gets into your system through respiratory tract, not through the skin, so it's not going to work. Garlic has been unproven so far, and a lot of people, they've been avoiding meat and animals to prevent from coronavirus. What do you think? I think that's wrong, because our animals didn't have the COVID-19 infection. And all the animals, the poultry and meat industry we have, are all grown from here or India, and those animals are not infected with COVID-19. So you can consume them, but make sure you cook them well, more than 70 degrees centigrade, and you use proper hand hygiene while handling the meat or cooking the meat, like in any other things we do. So the economic impact. I think we're sure that we're going to hit a big economic crisis after this COVID. A lot of big countries, they might go into negative GDP as per prediction. So we're seeing the things around. And finally, avoid handshake and go for namaste, which is our Eastern philosophy. I think that's going to prevent from a virus spreading. And we're going back to our roots, I guess. So I try to cover pretty much things I knew, but I think there are a lot of new developments going on and a lot of questions and new things coming up. So I might have missed that, or maybe the things I told you might have already changed. I'm sorry about that, but these are the things I thought would be important to get to the people around. And if you have any questions or suggestions, you can reach me out. And pretty much there are a few other videos important for doctors and nurses, and also for public, in my YouTube channel, Swasthya Sarkar. And also you can connect me through the Facebook page. And if you have any questions or new ideas, just feel free to chip in. All right, I think it's been 1.5 hours. Thank you very much for your patience. And I think there's one question that I would like to answer right now. So I get a question like, what's the reason behind mutation in COVID-19? So the reason is that COVID-19 is a heavyweight. It has a lot of genetic materials, because it is the heavyweight RNA virus. So anytime a virus or even bacteria, they divide, they are prone to get mistakes. So that means every time they are dividing or they are replicating, they do mutate, and they mutate a lot, and that's a proven fact. So some of these mutations get selected, and that's how the mutated virus gets into a new gets as a new virus or new serotype. So what I'm saying is that the virus, they mutate a lot, and if they get selected, they become a new virus. And the same thing is with influenza. The same thing is with HIV. So the viruses which have a lot of genetic sequence, they mutate a lot, and that's going on with COVID. And the second thing I get is that is vaccine is going to work. I think vaccine is going to work because there hasn't been a big mutation. There's only genetic drifting, minor genetic drifting, but no genetic shifting. There's no genetic shifting. So that means the virus changes a lot, but it doesn't change by a big margin. So I think there will be cross protection by the vaccine, or if you are already infected, so there should be some immunity with that. So I think if we roll out the vaccine, it's going to be more effective than influenza, but it may not be 100% like any other vaccine. So all right, so with this, I would like to end up um, my video here, and thank you all for listening to me. Bye, good night.